Okay, so this workshop is on assessment and management of suicide-related behaviors in children and adolescents. I want for this to be as informative to you and helpful to you as possible, so please feel free to ask questions, ask for more details at any point if anything is unclear. You don't have to wait until the end of the presentation. Now, before I get into this, let me ask a couple of questions just to get a sense of the audience here. I know some of you are students in training. Thank you very much for coming. How many are here are students in training? Raise your hands. Currently student? Okay, fantastic, wonderful. How many of you are clinicians, practitioners in the local area? Oh, yeah, some hands went down. The local area, okay, good. And then how many of you are clinicians, practitioners from farther away? Non-local? Wow, quite a few. Where do we have people visiting from? California. All right, can anyone beat that? Farther away than that?
I'm Vegas, but I'll give it.
Vegas? That's cool. All right, good.
I just visited your fair city.
Well, welcome to South Florida. Hope you're enjoying your time here. How many of you, especially those of you who are in practice, have conducted suicide risk assessments with children and adolescents? All right, good. Wow, maybe you should give this talk. How many of you do so regularly? Wonderful, fantastic. I hope the material I present today is going to be helpful. If you have additional suggestions or strategies, feel free to chime in, and we can discuss those as well. Let me give you an overview of what we're going to talk about for the next couple of hours. I'll start by presenting some information on the prevalence of suicide-related behaviors, including suicide and non-fatal suicidal behaviors. Then I'll talk about strategies for assessing risk and arriving at a risk designation. After we cover that material, we'll get into specific management strategies. That is, once you've determined risk, what steps do you take then? What are the courses of action? And I'm going to heavily emphasize one approach called safety planning. And then I'll cover the important issue of documentation, documenting what you've done. So let's begin with some questions and statistics regarding the prevalence of suicide. How many people, actually I'm going to start with homicide. How many people in the United States die by homicide each year? Who knows this? Or who wants to guess? Let's hear some guesses. How many people die by homicide each year in the United States? 13% of the population? So if we've got like 300 million, that's like 39 million die by homicide? I'll tell you, it's lower, fortunately. Anyone else want to take I won't say a stab. That's probably a portress term.
The third cause of death. I know it's the third cause of death in adolescents.
Okay, good. Okay, so if we're focusing on adolescents, the third leading cause of death, that's accurate. Anybody talking all age groups? Number of people who die by homicide each year in the United States? Okay. Yeah.
0.6%.
Okay, 0.6. Okay, give me a number though. Number of people, not a percentage.
1,000.
1,000. 13,000. So we've got 1,000, 13,000, and 39 million. We've got a good range here. All right, this isn't The Price is Right. All right? So no one can say 13,001. All right, how many people die by suicide each year in the United States? Don't be shy. More? More than by homicide? Okay. Anyone want to throw out a number? 100,000 a year? Okay. Okay. All right. We'll see. Let's move now to worldwide. How many people do you believe die by suicide each year globally?
40,000.
40,000. All right, 4,001, yes. The survey says. Okay, all right, let's start looking at this. Homicide. From the most recent year for which data were available from the Center for Disease Control, 2015, I believe, is what this is coming from. There were 17,793 people who died by homicide in the United States. So I think 13,000 or 13,001 would have been our closest there. This number, I've been given this some variation of this talk for 13 years now. This number has gone down tremendously in 13 years, which is very encouraging. It's good when fewer people are being killed. But it did go up. For the first time, it went up in the past year. From the previous year, it was about 15,000 who died by homicide. So after years of seeing the number drop quite a bit, it did jump up a little bit in the last year. Hopefully that is just a blip. That's not a trend, but we need to keep our eye on it. Now, let's look at suicide. How many people died by suicide in 2015 in the United States? 44,193. So more than twice as many people die by suicide as homicide every year in the United States. That's not something that's talked about a lot, doesn't get a lot of media coverage. Usually I hear people give much higher estimates or projections for homicides than suicide, but the reverse is true in this country. And sadly, this number has gone up every single year I've been giving this talk. When I started, it was around 28,000. Now we're up to 44,000. So the suicide rate has been going up. Yes? Does it include suicides that are misidentified? Let me respond to your question as best I can, and then let me know if I'm not addressing it. I think this number is a gross underestimate because there are many instances where the cause of death is inconclusive or it looks like it might be a suicide, but the medical examiner is not sure. In those instances, the medical examiner usually does not call it a suicide. And there are a number of reasons why that's the case. I suspect there are a number of instances where, for example, we see a single car crash. Someone's driving 100 miles an hour into a bridge abutment. It's probably not going to be classified as suicide unless there was a note. Was it a suicide? I don't know. In some instances, it might have been. So I suspect this number is really an underestimate of how many people die by suicide. Okay. Yes, question?
Does the number include, or do they consider a suicide if somebody overdoses?
Yes, if it's an intentional overdose and there's evidence that it was done with the intent to die, it would be classified as a suicide. Now,
That person has a history of substance abuse?
well, again, there can be some gray area. So if it's unclear, was it accidental, was it intentional? My understanding is that in most instances, the medical examiner, if it's not clear, is not likely to call it a suicide. Will likely call it an accidental overdose. Good questions. Worldwide, it's estimated that about 1 million people a year die by suicide. This, I think, is even more of an underestimate because there are many countries in the world that simply do not collect any data on the number of suicides, or in some instances, they may be motivated to underreport the number of suicides. So in all likelihood, this number is quite a bit higher. And these numbers within the U.S. or worldwide are substantially higher than the number of people who die not only by homicide, but also through any type of armed conflict, wars, and things like that. So suicide is clearly a problem. It's a problem that we cannot ignore. As I mentioned, there are over 44,000 people who died by suicide in the U.S. in 2015. It is the 10th leading cause of death in this country in all age groups. It is the second leading cause of death among young people, ages 15 to 24. Someone already mentioned homicide is the third leading cause. Suicide is the second leading cause in this age range. It is the sixth leading cause of death among children. On average, 121 people die by suicide each day in this country. That translates to, on average, one suicide every 12 minutes, which means approximately during the course of this presentation, 10 people in this country will die by suicide. It's a very common phenomenon, unfortunately. The rate of suicide in the United States is 13.8 per 100,000. Now, what that means is that for every 100,000 people in the population, 13.8 will die by suicide this year. So, for example, if you live in a metro area with 1 million, how many people would you expect to die by suicide that year? 138. 138. You multiply it by 10. Right. Exactly. So it's the number of people the rate is the number of people per 100,000 of the population that will die by suicide in any given year. some questions for you. You did okay with the first questions. Let's see if you do a little bit better with these. What age group in the United States has the highest rate of suicide? Older adults, okay. Seniors?
Teenagers.
Teenagers?
18.
Teenagers? All right, so we got teenagers, older adults. Okay, we'll see in a minute. Who is more likely to die by suicide, men or women?
Men.
All right, that was. Did someone say women? No? All right, that was a pretty strong men. Okay. Do the rates of suicide differ across racial and ethnic groups? Yeah, that's totally a leading question. I wouldn't have asked it that way if it weren't true. So which racial and ethnic groups have the highest rates of suicide? Caucasian? European American? African American men? African American men? Native Americans, I think I heard. Okay. Okay. All right, good. We'll see in a minute. Are people more likely to die?
I choose Native American.
Native American?
Men.
Native American men. Okay. Okay. All right, good. Are people more likely to die by suicide at certain times of the year?
Yes.
When? This is like the song that my kids learn in preschool. Winter, spring, summer, fall. Spring, winter, summer. Not during the holidays. After winter. Okay, all right. We've got a wide range here. We'll see. Okay, all right. Let's start with age group. This slide presents the suicide rate by age in the United States. And so what you can focus on here is, as you can see, the rate of suicide is very, very low in childhood. Sorry if I'm blocking your view. It increases dramatically during adolescence, kind of levels off in early adulthood, jumps again in middle adulthood, kind of ages 45 to 55, drops, and then rises again in older adulthood. So I don't think anyone said kind of middle adulthood is where we have the highest rate of suicide, but that is the case in the United States. That has changed in the past decade. 10 years ago and before then, what we saw was a flat line straight across here, and then it jumped up in older adulthood. But in the last decade, we've seen this age group really have a pretty sharp increase in the rate of suicide. And we could talk about potential reasons that's the case, but we don't have any causal data at this point. It would all be correlational data. What I want to emphasize, of course, for this presentation is this sharp increase we see in adolescence, because what this suggests is that adolescence is a crucial time period where we can identify people who are at risk and prevent suicide and hopefully alter their long-term trajectories to prevent suicide throughout the rest of their life. Okay, so that just reiterates what I said. Let's now look at gender. So you were right. Overwhelmingly, you were right. Men are much more likely to die by suicide in the United States compared to women. This presents the rate of suicide for men and women across the lifespan. As you can see, again, very rare in childhood. Although it is more common in boys than girls, we see a sharp divergence in the rates of suicide between boys and girls around puberty, with the rate really skyrocketing among boys and slightly increasing among girls. This remains the case throughout most of adulthood, but then in older adulthood, we see a very intense increase in older men, but not in older women. The rate actually declines slightly in older women. So that, if I go back a couple slides here, this increase we see in older adulthood is accounted for entirely by older men. They have the highest rate of suicide in this country, older men. Overall, the suicide rate is about 3 times higher in men than women. And we can look at some differences in the rates. At ages 10 to 14, there are about 2 suicides in boys for every suicide in a girl. Then it jumps up to between 3 and 4 in later adolescence. Then almost 6 male suicides for every female suicide once we get into early adulthood. All right, let's look now at race and ethnicity. Those of you who said Caucasian or European American had the highest rate, you are correct. The highest rate is among white Americans. The second highest rate is Native American, so those who said Native American were close. Out of the 44,000 suicides in this country, almost 40,000 were among white Americans. So they account for the majority of suicides by far in this country. The rates of suicide in other racial and ethnic groups that are measured by the Center for Disease Control tend to be around 5 to 6 per 100,000. Again, what that means is that for every 100,000 people in the population, 5 or 6 will die by suicide in a given year. So just to reiterate that, the rates of suicide we see in white Americans and Native Americans are 2 to 3 times higher than what we see in other racial and ethnic groups. And that's true for across the lifespan, including in adolescence. Okay, what times of the year? People most likely to die. Let's look at the data. These data are a little bit old, but trust me when I tell you that it really hasn't changed much. This is the average number of suicides per day across the 12 months of the year. As you can see, the lowest rate of suicide, lowest number of suicides in December. So whoever said not during the holidays, you're absolutely right. A lot of times when I talk to people in the general public, they think the holidays is when we see the highest number of suicides. Not true. It's actually the opposite. There's not a lot of difference here, but the highest rates are seen in late spring to early summer. So whoever said kind of spring to summer, you were correct. But the take-home point from this is that people die by suicide throughout the year. It really doesn't inform much in terms of what we do regarding assessment of risk. Okay, suicide methods. By what methods do people most commonly die by suicide in this country?
Men tend to use guns and more lethal ways of killing themselves, and women tend to use pills.
Okay. Hang on to that thought. Hang on to that thought. I know where you're going with it. Remember, right now we're talking about when people die by suicide. When people die. Firearms. What are other common methods? Hanging, asphyxiation, overdose. Yeah, you hit the big 3 that account for over 90% of all suicides in this country. 50% of suicides are due to a firearm. That percentage has gone down over the past decade, which is that's good to see. Unfortunately, the percentage of people who die by asphyxiation or hanging has gone up. That's now about 27% of people who die by suicide. 15% die by overdose or some form of ingestion. And then we have about 8% who die by the variety of other ways that people die by suicide. But by far the big 3 are firearms, hanging, and overdose. Now, something to note specifically about adolescents. Firearm is the most common method of suicide in adolescents, but the percentage of adolescent suicide by firearm has decreased quite a bit in the past couple of decades. And what we've seen, though, is a pretty sharp increase in the percentage of suicides due to hanging in the past decade. So that's something that is relevant, that can inform our courses of action when it comes to managing suicide risk, because we not only need to be thinking about access to firearms, we also need to be thinking a lot about access to methods of hanging oneself. And we'll talk more about that later. So let me summarize now some high-risk demographic features for suicide. If we were to put together a profile of who is most likely to die by suicide in this country, it would be men, it would be older men, it would be white men, non-Hispanic white men or Native American men, and those who have access to firearms. Those are the individuals that are most likely to die by suicide. If we were to try to create a profile of highest risk for adolescents specifically, we again would be looking at boys in this instance. Boys characterized by family and social disadvantage, meaning poverty, lower SES, a history of suicide attempt, that is, they've made an attempt in the past, they have a current mood disorder, depression usually. They also are facing current stressful interpersonal or legal life events. So that picture, adolescent boy, mood disorder, previous history of suicidal behavior, going through a major stressor. Maybe got arrested, maybe had a fight, maybe something broke up with a romantic partner. That would be the highest risk profile for adolescent suicide in this country. Okay, any questions thus far? Are you with me? Yeah.
I was wondering if you could talk a little bit about suicide among LGBTQ youth in particular, because I've heard that that's kind of a high-risk group.
Great question. We're going to get to that in just a minute. And if what I say addresses your question, perfect. If it doesn't, raise your hand and ask me again. Okay. Now, we're not going to spend much time on this, but very briefly, let's go over the psychiatric and social risk factors for suicide in adolescence. The distal risk factors include mental illness. We often talk about depression. We talk about bipolar disorder. Clearly, those are risk factors. But we're learning more and more that disruptive behavior disorders, including problems with aggression, are actually strong predictors of suicide in adolescents, especially in adolescent boys. So there's more and more research being focused on that. A prior history of suicidal behaviors, a family history of suicide is a distal risk factor. Impulsivity is a risk factor, and childhood sexual abuse is another risk factor. All of these predict which adolescents are at highest risk for dying by suicide over the long term, not necessarily the short term. When we look at proximal risk factors, things that in the short term predict risk of suicide, stress is a big one. Major events that happen in life, especially if they are interpersonal events, fights with family members, romantic disputes. The other area that's closely linked to adolescent suicide is a legal or disciplinary crisis. Being arrested, being suspended or expelled from school greatly increases the risk of suicide in adolescents in the short term. We can look at a number of cognitions or thought patterns, beliefs people may hold that are proximal risk factors for suicide. These include things like hopelessness, the belief things are never going to get better. There's no future, positive future for me. Poor problem-solving abilities, that is, difficulty generating solutions to problems and implementing those solutions, predicts suicide. The belief that one is a burden or a drain on others. That is, other people in my life would be better off if I were gone. I'm pulling them down. I'm causing problems for them. And then finally, a sense of social disconnection, that I don't connect, I don't belong. I'm lonely, I'm isolated. When you have those cognitions, especially if you put them together, it indicates short-term risk of suicide. Substance use is another short-term or proximal predictor of suicide, especially when you add it to some of these other things. We don't have really good data on this, but the leading theory is that substance use decreases some of the inhibition and fear that people may have about engaging in lethal self-harm. So when you have someone who's already thinking about suicide and you add substance use to the mix, it may increase the likelihood that they act on the suicidal thoughts. Okay, any questions about that? Great. Let's talk now about non-fatal suicidal behaviors. Suicidal behaviors that do not result in death. And there are a couple different types we can talk about here. One is a non-fatal suicide attempt, and this is defined as self-inflicted, potentially injurious behavior with at least some intent to die. That latter part is crucial. There has to be at least some intent to die. There are lots of adolescents who engage in non-suicidal self-injury. They may cut themselves, scratch themselves, burn themselves. If they have no intention at all of dying, we wouldn't call it a suicide attempt. Makes sense, right? But if there's at least some intention or some thought that this could kill me, we would call it a suicide attempt. And note that in adolescents especially, ambivalence is common. There will be some clear-cut episodes where adolescents will say, absolutely 100%, I intended to die when I did this. But more commonly, what you'll see is after adolescents have made a suicide attempt is they'll say things like, well, part of me wanted to die, but part of me didn't want to die. Part of me just wanted to end this pain. So ambivalence is common, but as long as there is some intent to die, we call it an attempt. Prevalence, non-fatal suicide attempt. When you look globally and across the lifespan, in fact, one of the presenters who was here earlier this week, Matt Knock, found a lifetime prevalence of almost 3% of people across the world, or at least from 17 countries, have made a non-fatal suicide attempt. The best estimate in the United States is that for every suicide, that is death, there are 25 non-fatal suicide attempts made. Now, let me be clear on what that means. That does not mean that people attempt suicide 26 times and on that 26 they die. No, what it means is that for every individual who dies by suicide, 25 others make a non-fatal suicide attempt. And that corresponds to about 1.1 million suicide attempts each year in the United States alone. It's estimated that there's one suicide attempt every 29 seconds in this country. So it's happening a lot. When we look at age, if I were to present a graph like I showed you before, the rates of non-fatal suicide attempt across age, the first part of it would look very similar to what we see for suicide. That is, the rates rise sharp, they're low in childhood, rise sharply in adolescence, but then they peak in adolescence between the ages of 15 and 18 years. That is when we see the highest rate of non-fatal suicide attempt. Following age 18, the rate gradually declines throughout adulthood. Now, these are some numbers that really concern me and bother me. I believe it was Dr. Jackson earlier who was presenting data from the Youth Risk Behavior Survey. I don't know, maybe I'm confusing presenters. Anyway, this is the survey that's done every year with high school students in the United States. Very large nationwide survey. The survey's found that 7% of high school students in the United States reported making a non-fatal suicide attempt in the past year. That's 7%. That is a lot of students saying that they have attempted suicide. 2% of students reported making a non-fatal suicide attempt that required some medical intervention. So one possibility with this 7% number is that there are a fair number of high school students who are saying they attempted suicide, but if we really investigated, we'd find out it wasn't clearly a suicide attempt. It was maybe some self-harm, but they didn't attempt to die. However, when you look at this number, at least 2% require medical intervention. So that would indicate at least 2% are engaging in suicidal behavior that's pretty serious enough to warrant a trip to the emergency room. And that's a high number when you think about it, 2% out of all high school students surveyed. Okay, let's look at the rates of non-fatal suicide attempt by gender, race, ethnicity, and sexual orientation. The rate of attempt is much higher in women than men. So we see kind of the reverse for what we see for suicide. With suicide, it's about 3 to 1, men to women die by suicide. The opposite's true with attempt. It's about 3 to 1, women are more likely than men to make a non-fatal suicide attempt. The attempt rate is highest in Native American and Hispanic female adolescents. So this also differs from what we see for the rates of suicide, which are typically highest in older white men. Well, the rate of attempt is highest in adolescent females, especially Hispanic and Native American females. Now, there's a caveat to this. What I have up here on the screen is true in California. It is true in Texas. It is true in New York. It is not true in South Florida. The rate of non-fatal suicide attempt among Hispanic adolescent girls in South Florida is not higher than what we see in other racial and ethnic groups. And we could spend quite a while talking about potential reasons for that. The bottom line is we don't know for sure. All we have is correlational data. There's probably a dissertation study in there for someone, but just know that in South Florida, that doesn't hold true. The non-fatal suicide attempt rate is also higher among adolescents and young adults with an LGBT orientation, getting to your question. Now, is the rate of suicide higher among individuals with an LGBT orientation? The answer is we don't know. We don't know. We don't have good data to answer that question. We have very good data from multiple studies, multiple research groups that indicate this is true. The rate of non-fatal suicide attempt is higher. We don't have good data on actual death or suicide. Does that answer your question?
I imagine it's tricky because you're not sure if folks don't necessarily self-identify.
There are a number of reasons it's tricky. One is just a numbers issue. The total number of people who die by suicide, especially adolescents, is relatively small. So it gets hard to make statistical comparisons. And then there's the issue you raise of we may not know for sure what someone's sexual orientation was, and they've died at this point. So we can't answer that question definitively, but with regards to attempt, the answer would be yes, it is higher among individuals with an LGBT orientation.
Do you know what the highest attempt rate is for South Florida?
Which group has the high? It's still going to be adolescent female. I'm trying to recall the data because I did look up the numbers. There are not meaningful differences between the different racial and ethnic groups in South Florida. But it's still women higher than men and adolescents higher than adults. Okay, method of non-fatal suicide attempt. And specifically among adolescents, the most common methods of non-fatal attempt are overdose or ingestion or cutting, especially in adolescent girls. In adolescent boys, we see more of a range. We actually see 1 in 4 non-fatal suicide attempts among adolescent boys involve cutting. 1 in 5 involve overdose or ingestion. 15% involve a firearm, but it doesn't result in death. It may result in a number of other serious issues, but doesn't result in death, and then 11% hanging. Okay, moving on here. The next non-fatal suicidal behavior we have to talk about is suicidal ideation. The definition of this is thoughts about killing oneself. And this can range a lot. It can range from very mild, transient thoughts to intense, prolonged, daily for hours types of thoughts. So there's a wide range of severity and frequency when it comes to suicidal ideation. Prevalence of suicidal ideation. Again, looking at adults, the best data indicate that about 3% of U.S. adults report suicidal ideation in the past year. It's much higher among adolescents, going back to these same surveys I've been talking about. In adolescents, 10 to 20% of high school students say they think about suicide or have suicidal ideation. And more specifically, 16% say they seriously considered a suicide attempt in the past year. 16%, very high. 13% said they reported having made a specific plan to attempt suicide. 13%. Very, very high and disturbing number that we're dealing with there. High risk factors, demographic features for non-fatal suicidal behavior, as we've talked about, include women, younger women, adolescents in particular, especially Native American and Hispanic adolescents, and adolescents with an LGBT orientation. That's the high risk profile for non-fatal suicidal behavior. Okay, the psychiatric and social risk factors for non-fatal suicidal behaviors are very, very similar to what we saw for suicide. So I'm not going to spend a lot of time on this slide unless you want me to elaborate on something here. No. Okay. So let's summarize this material on prevalence. Lots of people think about suicide at some point in their lives, especially in adolescence. In fact, if we go by the data, close to 20%, 1 in 5 people will think about suicide, especially in adolescence. A much smaller number will make a non-fatal suicide attempt. And again, this is most likely to happen in adolescence. Maybe as high as 7%, probably a little bit lower than that. A considerably smaller number of people will die by suicide, and this is most likely to happen in middle adulthood or older adulthood. All right, any questions before we move on to risk assessment? Okay, let's talk about assessing risk. We've covered a lot of information thus far. It's mainly broad group characteristics. Before I get into the strategies for assessing risk, I want to cover a couple of topics. This is an important point here. Suicide is what we call a low base rate phenomenon, meaning it happens way too much, 44,000 people per year in the United States. That's a lot. But when you're talking about a country of 320 million, it's still a statistically very rare occurrence. And these statistically very rare occurrences are impossible to predict with high accuracy in an individual case. If our goal were simply to come up with the most accurate statistical prediction model of suicide, we would always predict someone will not die by suicide. And we would be right 99% of the time. But the problem is that 1%. When we're wrong in suicide, in predicting the risk of suicide, the consequences are unacceptable. A false negative and a false positive, in both instances we get it wrong, but we don't weight those equally. A false positive is when we determine what? When we determine someone's at risk, but they're really not. Okay? And what are the potential consequences of that?
Excessive
Someone might get treatment they don't really need. False negative, what's that conclusion? With false negative, we conclude someone is not at risk when in fact they are, and the consequence is possibly someone dies. So we don't equally weight those when it comes to suicide risk assessment. Our goal is not to predict suicide per se, because we're not going to be able to do that accurately. Rather, our goal is to assess risk in a reliable, reasonable, and useful manner based on the variables that we know to be associated with suicide. And that's what we'll get into here in just a second. Now, I want to also address some common misperceptions or misconceptions about risk assessment. Like we see in this was an actual newspaper article title here. Think about it for a second. Okay. All right. So these are common misconceptions. These are things I've actually heard. You may have heard some of these as well. One is that if a person plans to kill himself or herself, there's nothing that can be done to prevent it. Look, you're wasting your time. If they're planning to do it, you can't stop it. I disagree. Another common misconception. Most people who kill themselves never tell anyone they're suicidal. Not true. Most people actually do tell someone or otherwise indirectly indicate that they're suicidal. The final misconception that I've been trying hard for a decade to dispel is that if we ask young people if they're suicidal, we are going to increase their risk because we're going to put the idea in their mind. That's just flat out wrong. We've got multiple studies with data showing that doesn't happen. In fact, and those of you who work with adolescents know, they already know what suicide is. If they're going through distress, the thought will have already gone through their mind. We are not introducing a foreign concept they haven't heard about, and we won't increase their risk if we ask them. In fact, the data indicate that when we ask, those who haven't thought about it at all are not at any higher risk, and those who are thinking about it report a reduction in distress when someone asks them, because that usually leads to a follow-up and the recognition that, wow, people care. Things may not be as bad as I thought, and there are ways to access help. So we're not going to increase kids' risk if we ask them if they're thinking about suicide. So now we know that. How do we ask? What are the best ways to do it? Let's talk about some strategies here. And most of what I'm going to present for the remainder of this workshop focuses on what you're going to ask and talk about with adolescents. But I want to emphasize it is important to get information from as many sources as you can, especially parents, primary caregivers. Make sure you ask them about adolescents' history of suicidal or self-injurious behaviors, as well as if they know of any thoughts or statements that adolescents have made. Sometimes parents won't know, sometimes they will. From time to time, I've been called to give kind of expert testimony on cases that have gone to court when an adolescent has died by suicide. And it's never an enjoyable thing to do. One of them I did recently. An adolescent was taken to a psychiatric hospital. He was evaluated, and during the interview he said, "No, I'm not thinking about suicide." His mom had filled out one of the forms in the waiting room saying, "He said he's going to kill himself and he's going to tell you whatever you want to hear just to get out." The person doing the assessment never spoke to mom. In fact, he discharged or denied admission to the adolescent when mom was in the restroom and didn't ask. Tragically, unfortunately, the boy later died by suicide, and then there was a lawsuit involved. But the big take-home message from that was, you gotta ask parents, especially if parents are there and are willing to talk to you and have information. Take it into consideration. The more informant sources you have, the more reliable and valid your risk assessment is going to be. Okay, so talking about risk factors, there are a lot of potential risk factors we could assess. You need to really kind of narrow things down and focus on risk factors that will directly inform your action steps. That is, focus on the risk factors that have the highest predictive validity and utility, and that's what we're going to do here today. And there really are two key areas that stand out when we're looking at short-term or acute risk of suicide. The first is a past history of nonfatal suicide attempt or self-injury. And the second area is current thoughts of suicide. So let's talk about these. First, past history of self-injury. The axiom goes, the best predictor of future behavior is past behavior. And that is certainly true when it comes to suicidal behaviors, especially in adolescents. A history of non-fatal suicide attempt is associated with, get this isn't a typo, this is accurate from the data, a 30-fold increase in the risk of suicide among boys. 30-fold, 30 times higher if adolescent boys have a history of non-fatal suicide attempt. 3-fold increase in the risk of suicide among girls. That's not trivial. That's meaningful. It's not nearly as high as what we see in boys. But the takeaway from that is if you're working with adolescents and they have already made a non-fatal suicide attempt, that gives you very, very important information when it comes to determining their current risk. 25 to 35% of youth who die by suicide have made at least one previous attempt, which is a high number. Of course, the flip side of that is 66 to 75% die on their first attempt. So you can't base your risk designation entirely on past history. There's a lot more to it. Kids can and do die on their first suicide attempt. This last bullet point is fairly new. There have been at least 2 studies in the past few years who have found that non-suicidal self-injury is as strong a predictor of future attempt as is a past history of attempt. So things like cutting is as strong a predictor of future suicide attempt as is a past history of attempt. So we need to add this into our risk designation and risk assessment approach. Not only have adolescents made a past suicide attempt, well, have they engaged in non-suicidal self-injury? We need to be asking that too. Question?
Do you have any information on behavioral rehearsal? So maybe not a full-on attempt, but kind of rehearsal, gathering needs, kind of going through.
I don't have data on that. I don't know of studies that have really examined that as a predictor of future suicide attempt or of suicide. In the absence of data, I would think that would be associated with a higher level of risk because that reflects plans, it reflects preparations, and I would, again, this is just speculation on my part, no data I know of, but I would speculate that it probably is going to lead to a reduction in the fear associated with engaging in that behavior and may make it more likely that they eventually act on it. Good question. Okay, here's a question for you guys. Among adolescents who have made a non-fatal suicide attempt, when is the highest risk for another attempt? Right after? 1 to 3. Are you cheating?
I was going to say, like, when there's an increase in their mood and they have more energy to complete.
Okay, that's a very interesting answer. And that's, for a long time, that was clinical lore, that when someone was severely depressed, they weren't really at risk for suicide because they didn't have the energy. But when they started to get more energy, that's when they're most likely to make an attempt. We don't have good data to answer that question. It's a plausible theory in my view. It could be the case.
When they have the next, breakdown?
When they have, so like the next...
Getting better, but
Next crisis, next stress. Okay, good. Well, the data indicate that it is in the first 6 months following an attempt. And really, the close immediately after is probably the best answer. In the first 6 months out to 1 year, we see 15 to 30% of adolescents who made an attempt will make another attempt. So what this indicates is this is a high-risk window. We can't, as clinicians, we cannot let our guard down. We need to be regularly monitoring adolescents, even if they appear to be, quote-unquote, doing fine. They still remain at risk during this time window. That's what the research tells us. So in addition to regular monitoring, this is a good time to consider, if you're working in an outpatient setting, to consider increasing the frequency of your treatment sessions during these weeks or months following an attempt. Now, this is another one I've seen when working on a legal case. There was an individual who's doing the assessment who said in his experience, an adolescent who had just made a suicide attempt wasn't likely to do it again in the near future because they had kind of learned their lesson. And you know, I mean, maybe in individual cases, there's some examples of that happening, but that's not a wise approach to suicide risk assessment because the data indicate otherwise. The data indicate that the first several months following an attempt is the highest risk window for another attempt. Okay, so the key point from this material on past history is that youth who have a prior history of a suicide attempt or non-suicidal self-injury are at elevated chronic risk, distal risk of suicide. And this elevated chronic risk or distal risk has to be considered. We have to take into account when we make an acute risk designation. That is, for the short-term, foreseeable future, we have to take into account their prior history. It will inform our risk designation. And we're going to come back to that in a few minutes. Okay, let's now turn to the other area that is crucial for assessing short-term risk of suicide. Current thoughts of suicide. The research that's looked at suicidal ideation has done things like factor analysis of measures of suicidal ideation, has found that we can divide the symptoms of suicidal ideation into two categories, or two factors. One of them we've labeled plans and preparations for suicide. This includes things like a sense of courage to make a suicide attempt, sense of competence to make an attempt, like, I can do it. Availability of means to and opportunity for attempt. Specificity of plan, like how specific is your plan for an attempt? Preparations, what preparations have you made for an attempt? And expectancy of attempt, like, do I expect that I'm going to do this soon? So that's one set of suicidal symptoms. The other set that emerges we've referred to as suicidal desire and ideation. And this is characterized by things like a wish to die versus a wish to live, the frequency of having the thoughts, reasons for living, and lack of deterrence to attempt. Now, here's the easiest question of the day. Which set of symptoms do you think is a better predictor of short-term risk? Yes, yeah, obviously. This isn't a trick question, all right? Plans and preparations. The data clearly confirm, and this is intuitive, this is a case where intuition and data align very well. Plans and preparations significantly predict higher risk of suicide attempt and suicide in the short term, and interestingly also in the long term. And that's what I've got on this slide here. We actually have a study showing that an individual's worst point plan, like the most serious, severe plans they've made in their lifetime history, predicts decades later whether they'll die by suicide or not. So it's a short-term indicator and a long-term indicator. Yes?
I had two separate occasions, that, like not even close to each other, of the parent reporting that this teen is giving away their things. Mm-hmm. Like, would you include that as preparation for suicide? Like, oh, you're going to have this because I'm not going to be here anymore. Like, it was really, indicating like, okay, they really have a plan. But would you? So
does that count as plans and preparations?
Yeah.
So my answer to that would be, it depends on, I would want to know more information. Something you said there kind of caught my attention. You said, because I'm not going to be here anymore. Okay. I'd want to follow up on that. If that's the statement, like, I'm going to be dead, so I'm giving this to you, then yes.
But what if it's not the statement, like, mom? Like,
So I would say, okay, I know she's giving some stuff away here. Tell me what's going on. What's that about? Yeah, you get right. If you get nothing. So, I mean, there can be a number of reasons why people may give something to someone else. But if it's giving lots of stuff and there's any sign that they're doing it because they're planning to not be alive, then I would, yes, consider that preparations for an attempt. But simply giving stuff away doesn't necessarily mean someone's suicidal.
Right.
Right,
if
yeah.
they are suicidal and you notice that what's going on.
Yeah. Preparations. Good question. Any other questions at this point?
I have have a question. I don't know how to focus the question, but do you have some data about suicide and mass murder, like these Columbine kids, like?
Yeah. Data, no.
Okay.
Data, that's another one where it's fortunately a very rare occurrence. So it's very hard to study and collect data on. And I won't go on a tangent, I promise. But it's very interesting. If you look at a lot of these mass murders, they almost all involve suicide. And what I think personally is someone first has made the decision to kill themselves, then they make a decision that they're going to kill a bunch of other people too. But they've already, by the time they decide to kill other people, they've already made the decision that they're going to kill themselves. But I don't know of any data on that, just because it's so hard to study. Okay, now let's talk about risk assessment. The two areas have to be covered, absolutely have to be covered. Past history of attempts and self-injury and current suicidal ideation, especially symptoms that indicate plans and preparations for suicide. So those are the key areas. That doesn't mean those are the only areas, but those are the key areas. And we'll talk some more about this in a minute. What I'd like to focus on now is on strategies for eliciting information. That is, how do you ask? How do you get this information? What are ways you can do it? And so I'm going to present to you some recommendations. You're welcome to follow them or not. I found them to be helpful, and we can kind of talk through them. I find it helpful to start by asking permission. This may seem kind of weird, like, well, why would you ask permission to an adolescent? Well, here's why. You start by explaining to the adolescent why this topic is important. That is, I'm concerned about your safety and your well-being. And you ask, is it okay for me to ask you about some of these things, to inquire about it? If the adolescent says yes, it's okay, then you've got a green light. You've got an open door. You've got the adolescent already kind of engaged and committed to the process. And that's a good first step when working with adolescents. Now, if the adolescent says no, you don't stop and say, all right, well, great, I'll see you next week. No, of course, you don't stop there. You explore the concerns they may have about talking about it. Like, maybe they're afraid if they tell you that they'll end up in a hospital. And maybe they've done that before and they don't want to do that again. Or maybe they're afraid you will think they are, quote unquote, crazy. Sometimes adolescents think, they haven't seen the data from the CDC. They don't know that 10 to 20% of adolescents are thinking about suicide. So they may believe, mistakenly, they're the only one that has these types of thoughts. If they tell you, you'll think there's something really, really, really wrong with them. There can be a number of reasons why adolescents may not want to talk about this. Explore those concerns if they say no. But then you've got to return to the importance of the topic. You got to return to it and say, I hear you. I hear those concerns. But I'm concerned about your safety, and it's really important for us to cover this and to proceed. And you try to continue that discussion until you get at least some degree of cooperation. Now, ultimately, you're going to do a risk assessment whether they agree to it or not. And that can be some useful information in and of itself. If they will not, absolutely refuse to interact with you on this, well, that tells you you can't be sure that they're going to be safe. And you may need to take some more restrictive actions. Yeah?
How do we go around the topic? For example, when I work, we have to do intakes that include first personal information, we go to our medical history. I don't know where pretty much it jumps into all those personal questions. Have you ever attempted suicide? Have you ever thought about killing yourself? How would you go around for asking permission? I work with adolescents mostly, like kids and adolescents. I usually try to tell them, it's for some sort of personal questions.
Yeah. Right, so it's not a good icebreaker, right? That's not going to be your first question.
During the first 24 hours that they meet us, it's like,
yeah.
Okay, no.
Exactly. And you've got to figure out in the particular setting and context in which you're operating, what makes the most sense. When is the most appropriate way to introduce it? Sometimes, if you're going through a set list of questions and you arrive at questions that are asking about symptoms of mood and distress. Sometimes that can be an appropriate place to insert this because you kind of lead into it naturally. You start asking about really feeling of being upset, of sad, or down, and that might be a good place to plug this in because you kind of flow naturally into it. But you're going to have to, whatever I present, it's got to be adapted to fit into whatever system you're working in. Okay, of course. Now, and I've got some examples here. Again, these are just examples. Maybe it'll be helpful to you. If you have other ways you prefer to say it, I encourage you to develop your own ways of how to present this. But one example is something like what I have up here. As we work together, my number one priority is your safety, your well-being. Sometimes when people are feeling upset, going through a difficult time, they have thoughts about hurting themselves or wanting to die. Is it okay if I ask you some questions about those types of thoughts? If yes, you're golden. If no, well then you explore the concerns that they might have and return to the topic. Okay, related to this, it's very important to, especially if you're going to be working with an adolescent repeatedly, so you're going to see them regularly, to set a precedent and an expectation that you're going to be asking them these questions. It should not come as a surprise. They shouldn't be like, whoa, I had no idea you were going to ask me that. And the subsequent actions you take shouldn't come as a surprise either. Now, you don't need to like walk them through all the possible steps that may happen, but you at least should give them a heads up that you're going to be asking about suicide, especially if you're seeing them regularly. You're going to check in on them, you're going to monitor them, and that you're going to take steps that are necessary to keep them safe. Confidentiality is a big issue here when we work with adolescents. They may not want you telling their parents something, and that's okay. Make it clear to them that you're only going to disclose information that is necessary to keep them safe. The other stuff, you're not going to share that with mom and dad. But if it's something related to keeping them safe, let them know up front, look, this is something that I will need to talk about with mom and dad if it comes up. And I know there's a potential reaction of, well, if you tell me you're going to do that, then you're just going to deny everything. That's a possibility. That's a risk. But the other side of that is if this is an adolescent you're working with regularly and you don't tell them you're going to take these steps, and then you take the steps, you've completely destroyed whatever rapport or alliance you've had. And they're not going to come back to you and open up to you again. Okay, I thought I saw a hand up, but yeah.
Well, I was just going to ask about, confidentiality, because in, different places that I've worked and had supervisors, a lot of times they'll tell me, when you first meet and you talk about confidentiality, you say exactly that. Everything we talk about is between you and me, unless it has to do with your safety, whether that's safety that somebody's hurting you, you're hurting yourself, or you're hurting other people. And we don't necessarily go too much into specific details, and sometimes we do. But in terms of I find myself struggling to know when exactly it is the time to use the information that they've given me to talk to other people, like their parents and things like that. Is it when they said, yes, sometimes I think about not wanting to be here sometime, or is it the planned part, or is it, and I find myself, thinking more so about the risk portion. I recently worked with somebody who was struggling with gender identity and their family rejecting them, and I knew that brought the risk up much higher at that age. So that is when I did address it with the parents, but sometimes it's a bit more vague and
Yeah, and unfortunately we do not have good data to guide our decisions here. We don't have good data to tell us exactly when is the point at which you should talk to mom and dad. We don't know, so we rely on our clinical judgment in those instances. Now, as I'll present later, I think in most instances, it is wise to bring parents in and involve them in things like safety planning. That can have a very nice therapeutic effect. Sometimes it's not the best thing to do, but that's going to require some clinical judgment because we simply don't have good data to drive those decisions, unfortunately. So mom and dad aren't always there. Yep. So it goes back to the point. What I present today, you're going to have to, if you want to draw upon it, feel free to do so. You're going to have to adapt it to optimally fit the setting you're in. Okay, so here's an example for how you might consider presenting this part. You could say something like, before we go any further, I want you to know that what we talk about today will be private and we will not talk about it with other people unless it's necessary to keep you safe. If I have concerns for your safety, I may need to speak with other people about that, including your parents. However, I will only share information that's necessary to keep you safe. I will not share the other things. Pretty standard language. You probably use some variation of that already in your work. Okay, more on strategies. It's better not to use the word suicide when working with children and adolescents, because some adults, frankly, may not fully understand what it means, and what we mean by suicide may not be the same thing as they mean. My youngest son is now when he was in first grade, he was saying something about, and he even called it superside. He said something about superside, and I said, superside, what are you talking about? He said, you know, when you jump off a tall building. Okay? So he didn't quite understand. He didn't even know the word, right? And he didn't understand exactly what it meant. He had some vague notion of it. It's better not to even use that word when you're working with children and adolescents. Use concrete terms that are less ambiguous and you know they're going to understand. That's going to lead to a more accurate risk assessment. So use terms like kill yourself, hurt yourself, think about dying. Those are not vague. Those are very clear terms. More strategies, and this is just general interviewing stuff here. Ask open-ended questions whenever you can. You're more likely to get the information you want, and you're likely to get information you hadn't even thought to ask about when you use open-ended questions. If you use only a yes or no checklist, you're probably going to miss important information. Now, a yes or no checklist may be helpful as an initial screening approach, but always follow up with additional questions. Okay, now getting into some more substantive recommendations and strategies. A very helpful approach is normalization. What do I mean when I say normalization? I'm looking at students, some of whom I supervise.
But they're not the only one that thinks these thoughts.
Exactly. Exactly. You normalize the behavior. And you do that to minimize a sense of shame, embarrassment, fear, reluctance they may have to disclose because they think they're the only one, or you might think they're crazy. So what are statements that can be used to normalize? Something like what I have on the screen. A lot of times when people are very upset, they will think about wanting to harm themselves or kill themselves. So you've just normalized it, and then you follow up with a question. And last week, how often have you had thoughts like that? You've told them you're not the only one if you have these thoughts. That can be an effective strategy. There are a couple of more strategies I'll present to you. This one here is a little bit stronger approach. It's called the gentle assumption. In the gentle assumption, you make an implicit assumption that the adolescent has already thought about self-harm or is engaged in self-harm. So this gets to how you word your question. So instead of asking, have you ever thought about killing yourself? And say, no, of course. You ask, when was the last time you thought about killing yourself? So you're kind of assuming they've had that thought. And you're more likely to get a response that's going to be informative. It's going to tell you when they had the thought, as opposed to a simple yes or no question. Another example is instead of have you ever tried to kill yourself, how many times? If it's 0, they'll tell you it's 0. I've never tried. But if it's 1, 2, or 3, you're more likely to get an answer when you ask it that way as opposed to have you ever. Okay, if you want to take it a little step further, especially if you sense that you're working with an adolescent who is resistant, not wanting to be there, not wanting to talk with you, and you sense that they're minimizing everything, you can use what's called the amplification assumption. The amplification assumption. What you do here is you make the adolescent feel more comfortable reporting self-harm behavior by assuming a degree of self-harm behavior that probably almost always is going to exceed what they've actually experienced. So instead of asking something like, how often do you cut yourself? Oh, no, I don't cut myself, no. Ask something like, in the last week, how many days have you cut yourself at least 5 separate times? Well, that's really, really, really rare. There aren't many adolescents who do that. And so what you're likely to get is an answer like, oh, whoa, 5 times? No, I only cut myself once last week. You see, they feel more comfortable reporting it, and they're like, hey, I'm not that far out there. I only did it once. I didn't do it 5 times. You've gotten the information you want by assuming a degree of behavior that goes well beyond what they're probably engaging in. And if they've never cut themselves, then they're just going to tell you, no, I've never cut myself. When assessing prior history of self-injury or suicide attempt, and an adolescent endorses a history and says, yes, I have tried to kill myself in the past, get as much concrete information examples as you can. When did it happen? Where did it happen? How did you try it? What was going on at the time? That provides information that can be very useful in identifying patterns of suicidal behavior that you can use in your treatment planning. You might be able to identify, okay, when this or this happens, that's when we're most likely to see an attempt. You can use that. That can be helpful to you. Okay, what are some measures to assess the symptoms and the behaviors we've talked about? There are a bunch out there. There are a few interview measures you could use. The Columbia Suicide Severity Rating Scale, that's a public domain scale. The Modified Scale for Suicidal Ideation, also public domain. Self-injurious thoughts and behaviors interview, again, public domain, all available to you. If you want to use a self-report questionnaire, those are probably going to cost you some money, but there are a couple or a few that include items that assess the types of symptoms we've been talking about. The Suicidal Ideation Questionnaire or the Suicidal Ideation Questionnaire Junior. You could look into those. Children's Depression Inventory 2 has one item that can be useful. I would not recommend your entire risk assessment be that one item, but that can be a useful screening item that you would follow up on. If you opt not to use one of these existing measures, there are other questions you could ask to get at the same type of information. And I have some examples of those here. Now let me ask you, do you have these slides?
Yes.
Yes. In an email. Okay. So, all right, so I'm going to move forward on the assumption that everyone has these or can access them instead of reading every single question to you right now. If for some reason you don't have it, send me an email. My email, I'll put it up on the screen at the end. Okay? But these are some questions you can ask just to get at the symptoms we've been talking about. And here are some other questions that you could ask to get at things like hopelessness, social resources, and deterrence to making a suicide attempt. Okay, when you are assessing risk of suicide, be systematic. Use the same approach with every kid you're assessing. When we deviate from that standardized approach, we are likely to miss important information, and that's going to lead to higher rates of making mistakes. And this point is really crucial. Never assume an absence of risk without asking. It can be tempting at times to think, nah, there's no way this kid is thinking about killing himself or herself. Don't assume that unless you ask. You'd be surprised sometimes what you find out when you ask about things. Always assess and do it as systematically as possible. And then a point that we'll come back to later, always document what you've covered when you assess risk. Okay, let's just kind of get into risk designation. Risk designation. How do we determine and what designation do we make? What I'm going to present to you is a guide. It's based on the available empirical and clinical literature, but I want to emphasize it is just a guide. When in doubt, when it comes to suicide risk assessment, err on the side of caution. This goes back to what I was saying before. False positive, false negative, we don't weight those equally. Err on the side of caution. Seek consultation when possible. If you're unsure about something, seek out a colleague who has experience with this area. What I'm going to present to you in this guide is going to emphasize the history of attempt and history of self-injury, as well as the types of the current thoughts of suicide. But, as we'll see later on, there are other things that can be relevant and that could bump up a risk designation to a more severe category. Okay, don't freak out when you see this. We're gonna work our way through this risk assessment or risk designation page here. But very briefly, what you'll see is on this diagonal, we have our risk designation categories. Low acute risk, moderate acute risk, high acute risk, and severe risk. And then on the vertical and horizontal, thank you, we have different ways that you will arrive at these risk designations. And we're going to walk through all the ways you can arrive at these designations. So let's start with the easy cases, the ones that we all hope to see regularly. But we don't, right? We're not going to see them regularly. The low-risk cases. Low risk would be an appropriate designation when there are no identifiable suicidal symptoms, when there's no past history of suicide attempts or self-harm, and when there are no or few other risk factors. That is, there's not a lot of major stress going on. The child isn't hopeless. They feel socially connected. That would indicate low risk of suicide. And so if you want to use this form as your risk designation tree, you would start here and look at, is this child at elevated chronic risk because they have a past suicide attempt or past non-suicidal self-injury? No. I move down. Do they have current suicidal ideation? No. Therefore, they are at low acute risk of making a suicide attempt. Make sense?
W versus not at risk, you always assume there's a low acute risk if they're...
Yeah, I don't like the term not at risk.
Although the low acute risk also, I mean, legally, kind of wonder sometimes is there going to be an issue, well, there was a risk, why,
Yeah.
terminology can...
And that's one reason why I prefer low. I think if you say there is no risk or non-existent risk, I think you're actually setting yourself up for more potential legal problems. But again, legal stuff gets messy anyway. So, but I prefer low to non-existent just because I'm assuming in the context in which we're working with kids that we're not out. I assume most of us are not like out doing purely like gifted child assessments. Kids are coming to us because there's some distress, some problem there. Okay. Next on our designation of risk, we have moderate risk level. This would be an appropriate designation for kids who have no past history of self-harm, but they do have some current symptoms of suicidal desire and ideation. They're having some thoughts of suicide. They do not have plans or preparations. They have no or relatively few other risk factors. Moderate would be appropriate in that instance. If a child has a past history of self-injury, they've already attempted, or maybe they've engaged in non-suicidal self-injury, they're automatically bumped up to moderate risk designation. It's based on the data showing that they are at much higher risk of making another attempt. So even if they don't have current ideation, if they have that past history, go ahead and bump them up and call them a moderate risk designation. So what would that look like on the chart? Well, going down this side, no past history. Yes, they do have current thoughts of suicide. They do not have a plan. And of course, by extension, no preparations. Moderate acute risk. Yes, they have a past suicide attempt. Do they have current suicidal ideation? No. We still call moderate acute risk. And here's why. Moderate indicates a risk level that is higher than what is found in the general population of youth who experience emotional distress or common psychopathologies and recent negative life events. Most kids we're working with will be experiencing some form of distress. That's why they're coming to us. Moderate risk indicates higher than that. They're also thinking about suicide, or they have in the past attempted to hurt themselves, or maybe even attempted to die. A moderate risk designation indicates a need to remain vigilant and attuned to any possible signs that a suicidal crisis could develop, and then take appropriate preventative action steps in the event that a crisis does develop. So moderate doesn't mean hospitalized. It's not at all what it means. It just means we need to be really on top of things and monitoring regularly and taking appropriate actions to make sure a child is going to stay safe. So, moving on up with our risk designation, we come to high acute risk. This would be the appropriate risk designation for individuals who have no past history of self-injury, but they do have current suicidal desire and ideation, a current suicide plan. They have a plan, but they haven't made preparations yet, or they don't have access to the means. So they can articulate a plan for how I'd kill myself, but I really haven't taken steps necessary to get those materials, or I don't have access to what I would need to kill myself. In that instance, high risk would be the appropriate designation. Now, if we're dealing with an adolescent who has a past history of self-injury, if they have current suicidal ideation but no plan, we would call them at high risk. They've already acted on suicidal thoughts in the past. They're having suicidal thoughts again. That indicates high acute risk. So here are the two pathways to high acute risk. This is the side for no past history of self-harm. Yes, ideation. Yes, plan. No preparations or access to the means of doing it. So they say, you know, I could take a whole bottle of pills, okay? Do you have that bottle of pills? Is it available? Is it in the medicine cabinet? No, I don't have. No, there's none of that available. Okay. So no preparations, still high acute risk. Now, on the other side here, those who have a past history of self-harm, they have current thoughts of suicide, but they haven't made a plan yet. We also call them high acute risk. High acute risk indicates the current presence of a suicidal crisis that could rapidly escalate to a suicide attempt. High acute risk does not mean we have to hospitalize the child at that moment, as we'll talk about later, but it means there's a crisis present and it may not take much to escalate up to attempt. We really have to be on top of things here. Okay, and then the highest risk designation is severe. For children and adolescents who have no past history of self-injury, this would be appropriate if they have suicidal ideation, they have a plan, they've made preparations, and or they have access to the means of doing it. So yes, I'm thinking about suicide. I would do it by taking my bottle of, my full bottle of Zoloft, and I have the bottle of Zoloft in my room. I know where it is. I'm going to do it, and I'm going to do it later this week. Or if, you know, if I get into a fight or argument with my mom and dad, I'm going to take it. That's my plan. All right, that's severe. If they have a past history of attempts, and they also have current ideation and a current plan, that is a severe risk. And here again, you can kind of see the two pathways to get to a severe risk designation. Severe risk designation indicates that an attempt in the near future is likely unless we take restrictive actions to prevent it. And that usually is going to mean hospitalization. Now, as I was just talking about with someone, we don't have good data showing that hospitalization reduces the long-term risk of suicide or suicide attempt. But for now, it's the best we have in the short term. If we think an attempt is likely in the near future, hospitalization remains our best option for keeping a child safe. Important point. I want to drill this in. This is just a guide. I caution you against inflexible adherence to it. If you're going through this and you come out of risk designation, but you also identify multiple other risk factors, such as a major life event that just happened, substance use, family history of suicide, childhood history of sexual abuse, a higher risk designation may be appropriate. When in doubt, err on the side of caution and seek consultation from experienced colleagues. I think the guide is generally good and appropriate, but if you're at a point on that guide where you're not comfortable, you think there's some more things going on that need to be factored in, do that. Do that. Again, err on the side of caution. When you have a child or adolescent you've designated as low risk, here's my recommended course of action. The good thing is you don't need to take any immediate actions or steps, but I recommend saying something along the lines of the following to the child. Thank you for talking about this with me. I'm glad to hear you're not having these types of thoughts, and I hope you never do. But if at some point you do, in the event you do have thoughts of harming yourself, here's what steps you can take. And you identify appropriate sources of support and help, like family members, counselors, hotline numbers. And then you document that you had that conversation. Again, the data tell us that having this conversation, you're not going to increase the child's risk of having the thought in the future. But what it does is, in the event it does develop, they at least have some idea of what steps they can take to get help. Okay, moderate risk. What are courses of action? Here I recommend developing a safety plan. We're going to talk more about that later. Just out of curiosity, how many of you have developed safety plans before? Awesome. We may not need to talk much about it then. I'm really happy. This is one of those things where over the years, the number of hands that go up has increased a lot. So it's almost everybody, I think, raised their hand. That's great. So other things to do at a moderate risk designation. Involve family and support of others. We'll talk about some ways to do that. Frequently check in with the child and with the family to monitor their status, to address stressors that you've identified, and to facilitate symptom resolution. Like if they're coming in for treatment of depression or for anxiety, work with them, frequently monitor them, try to address those symptoms and those stressors that are present. And you may also consider telephone contact for monitoring purposes. So, okay, we're going to meet once or twice a week. In between sessions, let's just do a quick phone check-in to see how things are going. If you're working in outpatient treatment and the adolescent is not taking any sort of medication, you might consider a referral for medication evaluation in that instance. And then, as always, you're going to want to clearly and regularly document the risk designation and the courses of action that you took. Now, something I haven't said, but I also want to emphasize, is that the risk designation can change rapidly. Okay? If you determine risk is moderate, that doesn't mean it's going to stay moderate. Or risk is low. Doesn't mean it's going to stay low. It can go up or down. Hopefully it's going to go down, especially if you're in treatment. But depending on what's going on in environments and contexts, that risk designation can go up pretty quickly. That's one of the reasons we need to regularly assess risk. This is just an example. This should look familiar to some of these students over here. This is what we developed for what we do in our clinic. Some things you can say and do when a child is designated at moderate risk. So, here it is. Thank you for talking about your thoughts and feelings with me. Sometimes it can be hard to talk about distressing thoughts and feelings. My number one concern is your safety. Let's work together to come up with a safety plan. And then you do that. Then it's also important for your parents to know that you've been having these thoughts. You've been having thoughts of killing yourself. Once they know you've had these thoughts, they can help make sure you stay safe. I'm going to bring your mother or father in now, and we can talk about this together. Then you bring the parent in, you review what you've discussed, you review the safety plan that's been developed, you revise it based on parental input, you discuss the importance of open communication and monitoring. Now, there are different ways to do this. In some instances, you may want to bring the parent in earlier, especially with a child. You may want to bring the parent in to have the parent help develop the safety plan. But with an older adolescent especially, you may develop the safety plan together with them and then just bring the parent in at the end to review it with them. And then at the end, state something along the lines of the following. In the event the thoughts worsen, you're unable to access help, you feel things just can't wait, call 911 or go to the nearest emergency room. Okay, course of action with a high acute risk. You need to continuously monitor the child or the adolescent. Is that a question? Yeah.
Yeah, with the modern course of action, when you're saying safety plan,
Yeah.
is this a written formalized safety plan or a discussion safety plan?
Written.
Written.
Yeah, written, formalized. Yeah.
So I have a follow-up to that. I'm just curious what your thoughts are. I was at a similar workshop to this at one point, and the individual who was putting it on recommended that more from a liability perspective, you should always have a suicide contract with any patient regardless of plan. Have you heard this before, and what are your thoughts?
I've got a slide on it.
Oh, you do?
Okay. We'll get to it. Yeah, it's a great question. It comes up a lot.
Okay.
We'll get to it. But in response to the safety plan, I recommend written, or with adolescents today, you have it here. There are safety planning apps. There is an app for everything. There are safety planning apps. They can have it on their phone. Sometimes I recommend having a written hard copy because sometimes phone batteries go out. And when someone's in the middle of a suicidal crisis, they're not good problem solvers. That's not when you want people to be problem solving. They need to have already worked the stuff out on the safety plan, and they can just look at it and say, here's what I'm going to do, whether it's on my phone or whether it's printed out. That's why I recommend having it written as opposed to a conversation. I don't want an adolescent who at 2 in the morning, suicidal in their bedroom, trying to remember, okay, now when I met with Dr. Pettit, and what did I say I was going to, I don't want them to have to think about it. I want it right there in front of them. Oh, this is what I'm going to do. This is who I'm going to call. These are the steps. Okay. So at high, continuously monitor. We don't want children and adolescents to be left alone when they're at high acute risk. So when they're at your clinic, you're monitoring them. When they're not at your clinic, parents, some other adult needs to be monitoring them all the time. This is absolutely the time to involve family members and to involve family members in what we'll call sanitizing the environment, making the environment safe, removing possible methods of self-injury or self-harm. And we'll talk more about that. Here again, develop a safety plan. And if the adolescent is not able to agree to follow the plan, or the family, the parents, are not able to monitor and keep the environment safe, this is the time to consider hospitalization. Now, if you're able to develop the plan, the adolescent works together with you to do that, and parents are on board, they understand, they agree to take steps to keep the home safe and to monitor, then you don't necessarily need to hospitalize at this point. In fact, it may in some instances be counterproductive to hospitalize at this point. When we get to severe risk, yes, hospitalize. But at this point, if the plan's developed and everyone is on board with it and knows what to do, you don't have to hospitalize, yes.
Maybe it's a silly question, but what happened in the hospitalization? Like, what do they do?
That varies, okay? So not every child's hospital experience is the same. It depends where they go. Oftentimes, this is kind of just a typical route. Family may go to emergency room. They'll be there for a while, be evaluated, and then if a determination is made that they need to be hospitalized for a period of time, they may be transferred to, sometimes within the same hospital, a psychiatric unit, sometimes a different hospital to a psychiatric unit. They're going to be there on average from 3, maybe up to 7 days. They're probably going to be receiving a fair amount of medication in many instances, sometimes antipsychotics, other things to kind of calm them down. They'll probably be engaging in some types of group therapy. Maybe they'll bring family members in and do some family therapy. Then they're going to be discharged and given recommendations for outpatient treatment. That's kind of the typical, right? Those of you who work, am I leaving important stuff out?
Yeah, I just wanted to add a little bit to that too.
Okay.
I worked for several years at a pediatric hospital, and did a lot of, I couldn't admit myself as a psychologist, but I worked together with those who could admit. But my decision would be the one about whether or not they could be admitted to our psychiatric facility. So we had an in-house psychiatric facility as well. And so I also spent some time at that psychiatric facility for some time, which was great for me to learn what happened in there. Which unfortunately, one of my biggest frustrations is that the community didn't really know what happens in there. We have these really high expectations about what sometimes happens in child and adolescent psychiatric units. I can only speak to this one, obviously. But our stays were on average 3, maybe 4 days max. There have to be very severe situations for there to be someone there for a week. And I think that one of the frustrations that I also encountered was many times I would actually see the same patient come back in, a couple weeks later through the ER, because there's a lot of misuse of ERs. And I think that education is so necessary in the community, and all of us being providers. Different states, I've worked in other states where I think there were other services available that could be helpful where I was. But, within regards to being in the unit, like you said, there's a family meeting. There was a psychosocial intake, I think they called it. Then there was a family meeting, group work, but there was not much individual work whatsoever.
I'm glad you're raising it. It's an excellent point. There's not a lot of time or opportunity for treatment to really address the issues that may have led to a suicidal crisis. For the most part, it is purely crisis stabilization. We're going to hold the child adolescent here to make sure they do not harm themselves for a short period of time, but as soon as we think they're stable, they'll be discharged. And they may be discharged, in many instances, to exactly the same setting and stressors and factors that led to the crisis in the first place. So that's why my personal recommendation is to consider hospitalization strictly as a last resort. If the environment can be made safe, it is better to continue working on an outpatient basis for a number of reasons. One, you're going to continue to work with your client and their family. If hospitalization happens, your family may not come back to you, especially the adolescent. If they sense that you are willing to work with them and do whatever you can, short of hospitalizing them, to help them, I think that's going to help your alliance and it's going to lead to a more positive outcome. Having said that, there's some instances where you don't have any other choice but hospitalization. Okay, courses of act. Okay, yeah. Okay, I'm going to skip that. Okay, so speaking of when you don't have any other options, severe is when it's time to immediately evaluate for hospitalization. The child or adolescent needs to be accompanied and monitored at all times. You don't leave the child in the therapy room to go talk to parents. You don't leave them alone. Someone needs to have eyes on them at all times when there is severe risk. Family members need to be involved if family's not present. Police, whoever, somebody needs to be involved to facilitate keeping them safe, and that's probably going to mean, at least for the short term, a stay in a hospital. And some of the other recommended activities apply here as well. Some tips for phone assessments. So sometimes if you're working in outpatient settings, you may develop a safety plan and work with the child, and then between sessions you want to do a phone check-in. Okay, I'm concerned. I just want to check in to see how things are going. When you do a phone assessment, always make sure you've got their current phone number in case you get disconnected. Always obtain the current physical address. That is where they are right now the moment you're talking with them, in case you do need to call the police. If they hang up on you and you think they're suicidal, you call the police, but you can't tell them where the person is, it's not going to be that helpful. So get their phone number, get where they are at the moment. And then this is the harder one, but be patient and stay on the line. Don't expect this to be a short conversation. You may need to stay on the line for quite a while in these instances. That's the nature of what we do when we're dealing with patients who are suicidal. And then, of course, consider a follow-up call the next day. If you resolve things that day and determine they're not at severe acute risk and the environment's safe, consider another follow-up call. Some tips for contacting police. Well, we probably don't have time to get into it, but maybe afterwards I'd be interested in hearing some of your experiences if you've called the police and dealt with them during this. I recommend asking for a crisis intervention team officer. Many police departments have individuals who have received special training in handling these types of crises. That does not necessarily mean they're going to handle it well. Okay? But the chances of it going well are better when you're working with a crisis intervention team officer as compared to someone who hasn't had any training in this. And I did a recent check for kind of the local area police departments that have crisis intervention teams, and these are the cities and towns where they have, at least they list, having crisis intervention team officers. So you can just ask for that if you call 911. Inform the police who you are, where you're calling from, and exactly what you need. That you need involuntary evaluation and transport to a receiving facility because you have a client who you think is at risk for hurting himself or herself. This is not the time to get too worried about confidentiality. Provide the information they ask for. Don't use jargon or provide diagnoses. Police won't care about borderline versus, you name it. Don't even go there with them. And then when they arrive, let them handle the situation. It doesn't always go the way that we would want it to go. I mean, it's not always handled that well. Sometimes well, I'll leave it at that. Sometimes it doesn't go the way you would want, but once the police have stepped in, you got to step back. And I would not recommend trying to tell the police what to do. That's not going to go well. Now, you can go to the emergency room separately and be there and try to help and facilitate, but once you've made the call to the police, it's really in the police's hands at that point. Okay, any questions? Yes?
I guess I'm wondering why the police and not like a mobile crisis unit if one is available, or why the police and not 911 and ambulance if that's available. And if the parents call 911, are they going to be connected to the police versus an ambulance? I guess I was just a little confused about
Yeah,
that.
you're going to get, yeah, if you call 911 and you mention that you're concerned someone's at risk for killing themselves, the police are going to show up. Yes.
Right, the
Yes.
fire usually, and I don't know if it's in all jurisdictions, but usually even the paramedic doesn't do that assessment. The police have that designation. And the crisis units, the problem again is in California, if you call after like 3 in the afternoon, they're not going to come. And if you call at noon, if they get there by 3, that's good. So those are the problems that, just being real, those are the problems that you face.
It's absolutely accurate, unfortunately. But so although I mean, look, that's when you have to call the police. If you're there with parents and adolescents, and parents understand the severity and appreciate it, and parents know where the hospital is, and parents are willing to take the child to the hospital, that's preferable. That's preferable. They can do that, and it goes from there. But there's some instances where that's just not an option, and you have to call the police. And hopefully they handle it well. Sometimes it doesn't go so smoothly, but when you got to make that decision and make that call, you got to make that call. Okay, yeah, question.
My question was kind of similar because this happens to us a lot where we're off-site from our receiving facility.
Yeah.
And then we call the police and the police come, but if we have a professional on site who's initiating a PC, so the police always say if they're not the one initiating the Baker Act or the involuntary hospitalization, they will not transport. And they will also, if the person is not actively agitated, they're not going to initiate it anyway. But usually we have a professional to involuntarily admit, but we need safe transport to the facility. So then they call the ambulance, and the ambulance says no, call the police. So we get into like this whole thing, which ends up being really traumatic for child and family, sometimes even more so than other things. I was just hoping you had a better answer.
No. I wish I did. That's, again, where I'm saying sometimes it just does not go well. Sometimes you get this, like, no, we won't do it, or we won't do it. Sometimes you get police officers who are just kind of like overexcited and they run in, they've got their lights on, and they slap on the handcuffs and walk them out in front of everyone with handcuffs.
Or on the stretcher. If
on
the
the
ambulance
stretch-
is on the
yeah.
stretcher, they have to strap them down.
Yeah. But yeah, so unfortunately, I don't have any great suggestions or ideas. In fact, if you do, let me know, and we'll share them with everyone. Yeah, one comment, then we got to keep moving here.
What type of people are able to put in a request for a Baker Act? Like, for example, in my case, I have my master's degree in counseling, but I'm not licensed yet.
That's right.
And I'm working at a school, and I don't have a supervisor on site. I have on my phone. And so if that situation happens, would I be able to make the call myself? No.
No. So you would need the police there. Or again, the ideal scenario is if family agrees to it and they go to a hospital themselves. But if they don't, or family's not available, then yeah, in that instance.
So I would just call the police, and then they would come and assess whether they'll take them to.
Yes.
Okay. Got it.
Yep. That's right. Good question. Okay, let's talk now about some management strategies. Myth or fact? No suicide contracts in which the client signs a document or verbally agrees not to attempt suicide during treatment are an effective intervention and method of managing risk. Myth. Myth. This used to be the standard practice. It is not anymore. No suicide or no harm contracts are neither effective nor legally protective. They won't protect you legally. there's research demonstrating that suicides happen when a no-harm contract is in place. And one of the problems with no-harm contracts is that they tell people what not to do, but they don't tell them what to do. They don't give them any skills to help them manage the crisis. It's just kind of promise you won't kill yourself and sign here. Okay, you agree to it. But then, well, what are they supposed to do? What skills do we give them to help them manage the crisis? I think no-harm contracts are most efficacious in reducing therapist anxiety. But they're not an effective intervention or risk management strategy. And they could discourage patients from talking about thoughts of suicide. If it's, oh, when I mention suicide, you put this out and make me sign a contract saying I'm not going to hurt myself, then why do I even bring it up? All right, I'm not going to bring it up again. So instead of a no suicide or no harm contract, make a safety plan. A safety plan, the nice thing about a safety plan is it tells people what to do. When you're feeling suicidal, here's what to do. It is a collaborative approach with the adolescent and ideally with the parents to develop a written list of specific sequential steps that they will follow if suicidal thoughts emerge or reemerge. The plan should be written and easily accessible at all times. Now, because almost all of you said you have done safety plans, I won't spend a lot of time on it, but if at any point you want me to slow down or you want to ask questions, please feel free to do so. So as you know, with safety plans, you begin with internal strategies. These are activities that the adolescent can do by themselves to cope with the thoughts or the urges they're having without seeking assistance from others. If those work, fantastic. If they're not sufficient, then we step it up to actively enlisting help from others. So step one is recognizing the warning signs. What are warning signs that indicate a suicidal crisis may emerge? When I'm feeling really down, I'm feeling hopeless, or I have the thought I just can't take it anymore. Those are cues. Those tell the adolescent, okay, I'm having this thought, I'm feeling this way, that means I need to use my safety plan. Step two, we develop a specific list of activities the adolescent can do by himself, by herself, to cope with the suicidal thoughts without enlisting the help of other people. And the primary aim here in step two is distraction. We want to distract them from the crisis, from the suicidal thoughts. Maybe it's going for a walk. Maybe it's listening to inspirational music or playing with a pet or engaging in a hobby. It can be all kinds of different things, but it has to be specific and it has to be personally relevant to the adolescent. One of the potential problem areas or pitfalls with safety planning is coming up with a generic safety plan that's not personally relevant to the adolescent. They're probably not going to use it if the activities aren't that relevant to them. Need to be very specific. Like, for example, on a safety plan, we wouldn't put listen to inspirational music. Why not? Well, that's vague. What's inspirational music? You write down, okay, well, what's your favorite, what's your favorite band? What's your favorite song? What's your favorite, and you write specific, I'm going to listen to this. Or you wouldn't write, well, I'm getting to the next one here. But the key is be specific. And oftentimes when working with an adolescent and you're doing a safety plan, they'll be kind of vague. So you've got to help them and facilitate being very specific with it. Okay, step three, use social contacts and settings. So after you've used these internal strategies, whether it's listening to your favorite band or going for a walk or painting or whatever it is that you do, you've tried that, but you're still having these thoughts. You're still in a suicidal crisis. What's the next step you do? Well, you contact people that you can interact with and socialize with. At this step, you're not contacting them to say, I need help. You're contacting them, again, with the goal of distraction. So you generate a specific list of people or places where socializing occurs naturally, like hanging out with specified friends at a specified park, coffee shops, places of worship, talking with this friend, that friend, calling them. And crucially, you want to identify people at this step who are good distractors from suicidal thoughts not co-ruminators. So sometimes adolescents have friends who have similar types of problems. You don't want a situation where when they're in a suicidal crisis and they're calling just to kind of get their mind off it, they're talking to someone else who is kind of going through the same stuff. Not a good combination there. Make sure it's someone who's going to be kind of positive, upbeat, distract them from these thoughts they're having. Step 4, you've tried that. You've tried the internal stuff. You've tried talking to friends, interacting with others. Step 4 is actively seeking help, using social contacts for assistance. You identify a specific list of adults. And yes, at this stage, this step includes adults. These are trusted adults. Could be family members. Sometimes family members are not the best people to put here. Sometimes with family members, it's going to escalate the crisis rather than de-escalate it. So you need to kind of sort that out as you're developing the safety plan. It could be family members, it could be friends, could be teachers, could be neighbors. Doesn't really matter who it is as long as it's a trusted adult who can help the adolescent during the crisis. The adolescent will inform them they're having these thoughts and that they need help. And ideally here, you're listing people who know about the safety plan. Or you list people and then, if they don't know, you talk to them. And the adolescent talks with them to let them know, hey, I have this is my plan to be safe. If I reach a point where I need help, I may be reaching out to you, okay? Let them know about it in advance. Question?
What are your thoughts about with the social contacts, rather than putting it on the adolescent to reach out all the time, enlisting those kind of key adults, teachers, coaches, to check in on a regular basis, to help kind of.
Yeah, I think it's an excellent idea. Excellent idea. The only challenge is those people in the environment may not know exactly when an adolescent is going through a suicidal crisis. So the adolescent at some point is still going to have to reach out. But absolutely, if you have supportive others, especially those who know about the plan and know the adolescent is going through a hard time, enlisting their support and kind of checking in and providing support to the adolescent, absolutely. Use that resource if it's there. Okay, step 5. If you've tried the other things, you've done the internal strategies, you've talked with friends or others, then you've actively sought help from adults, things are still not going in a good direction. Step 5 is when you contact mental health professionals or agencies. And here, again, specificity is the key. List specific professionals or agencies that can help during a crisis. You list their names, you list their phone numbers. You can include hotline numbers here. This is the nationwide 24/7 line 1-800-273-TALK. More, and I added this line just this year. More and more adolescents like to text. If I were in a crisis, I don't think I could do it very well, but adolescents are good at it. So there are now text lines or chat lines where they, instead of calling and speaking, they can text and reach a hotline number. You also want to list the contact info for the local emergency treatment facility, like what's the nearest hospital. If you need to take to an emergency room, where's the closest one? Where are you going to go? Work out these details in the safety plan again. So when the crisis happens, people don't have to problem solve. It's already been solved. They just follow the instructions at this point. You also at this step want to identify potential roadblocks for seeking assistance. So for example, you don't want to list a bunch of professionals here who just maintain normal hours and aren't available late at night or on weekends. You need to make sure you've got people who are going to be available around the clock and figure out what are potential things that could prevent them from seeking help at this step and address them. The final step in safety planning is means restriction. That's restricting access to potential methods of self-harm. So you want to identify together with parents and adolescents or children what may be available in the house and how we can restrict access to it temporarily to maintain the safety of the child. A general goal of the treatment we do is to reduce the adolescent's pain, which in turn we think is going to reduce the risk for suicide. You can present means restriction as a method for facilitating safety in order to give treatment time to work. So here's another myth or fact. Restricting access to lethal means like firearms, bridge barriers, and so forth does not reduce suicide deaths. Individuals who want to die will simply find another method. Okay, I guess we don't have these in South Florida, but there's some bridges that are common places for where people jump and die to suicide, and they put up nets or other barriers that prevent that from happening.
If you go online, they have like the 10 top place bridges.
Yeah. And this is not to get on a tangent, but it's always controversial. There are always people on city councils who strongly oppose doing this because they say, well, it's not going to look nice. It's going to be ugly. We don't want to do that. But what do the data say? The data indicate that when you restrict access, we don't see a corresponding increase in other methods of suicide. Most suicidal crises are time limited. If you make it hard for someone to act on it, they're less likely to do so, and then the crisis is going to pass. So means restriction is simply a way of preventing the possible options for self-harm until the crisis has passed. Okay, that's just what I said. So when we do means restriction counseling with parents and adolescents, we provide psychoeducation. We talk about the risks associated with access to lethal means, and then we come up together with them a plan to limit that. And so sometimes this involves firearms. There are firearms in the home. What do we do? What can we come up with? What plan? Lock the firearm, give the key to someone. I recommend outside the home. I recommend outside the home. Tragically, another case that I'm aware of, the dad was convinced the adolescent had no way of getting the lock to the gun safe. Adolescent got the lock to the gun safe, and adolescent killed himself using dad's gun on dad's couch. Get it out of the home, temporarily, or remove a critical piece of the gun, give it to someone else, remove the ammunition, and again, you might encounter some parental resistance, but emphasize this is a short-term thing. We're not telling you you've got to get rid of it entirely, but while your child is in this crisis, we want to make it as safe of an environment as possible. When it comes to pills or medications, if you've got old unneeded medication, dump them out. You don't need a large quantity of pills here when someone is suicidal. Use pill boxes to distribute weekly medications, or give the pill boxes to the parents to keep. So adolescents, just make it harder and harder for them to have access to a large number of pills. That's the goal with means restriction. Now, creating the plan is necessary, but it is not sufficient. You also need to follow up to make sure the plan was implemented. So speak with the parents about their role and then follow up with them to ensure the plan was followed. And if it wasn't followed, problem solve. Figure out, well, what happened? What made it hard to implement this? What can we do differently to make this environment safe? Okay, here's an example of a safety plan. Again, you've done these things, so I don't want to belabor the point. But if you have questions, let me know. Yeah?
I have one question. So in your example, you gave several steps with means restriction being the last step.
Yeah.
And in other, I guess, workshops that I've gone through about evidence-based things for suicide, means restriction is actually the first step. Is there any reason why that's kind of left as the last one?
I think it depends how you approach it. So if you're talking about like big picture prevention strategies for suicide, well, means restriction is one. I'm talking specifically in the context of a safety plan.
Yeah, that's what I mean as well.
Yeah. The reason I have it last is because in many instances you're going to be working with an adolescent alone to develop those first 5 steps. What are the strategies? And then you're going to need family members to really implement the means restriction piece. So that's the time at which I would say bring families in and let's talk about the whole plan and add means restrictions there. Now, if you've got the whole family together from the beginning, from step 1, sure, you can do means restriction first. I don't think there's any, like, you got to do it this way or that way. All I would recommend is make sure you do it sometime, whether it's the first thing or the last thing you do. Any other questions about safety planning?
I mentioned it earlier, but I work at a school. But there are a lot of schools that don't necessarily have a mental health professional on in the school campus. What would you recommend, you know, if I'm traveling around to schools and they don't have a mental health professional on site, how would they typically want to deal with any students that may come up to an adult and say, sometimes I have these thoughts, or you know, what would be like their plan of action in that case?
I don't know. Who works in schools here besides you? So what, in these situations, if you don't have a mental health counselor that's always in the school, what's the plan? I assume there should be some sort of plan.
There has to be a counselor at the school at all times.
Plan is march on Tallahassee.
Yeah.
I mean, the truth is that the monies for mental health, the talking has gone up, the monies have gone down. So it's really tough. I mean, some of the things you were talking about in terms of like calling parents, we're not supposed to call parents unless there's not a crisis. You know, when the kid is in the police car on the way, you call the parent.
Wow.
Yeah. Well, actually, I'm an LCSW in the schools, and we do have a. I work with Barinkin Medical Center, so we do have a contract with the Children's Trust, where we provide a school health team in the schools that we're awarded. So we have a nurse, LPN, and a licensed mental health professional, LCSW or mental health counselor. Now, like she said, all schools should have either a trust counselor or a school counselor.
And then the school psychologist.
Right, the school psychologist, right. Do you know?
Well, I'm at a charter school.
That's probably why.
You'll still be able to call whoever is your supervisor.
Right.
That should be the person that's
It's
available
a little
to
bit
you.
different because I'm an independent contractor for a company that
Right.
has a contract with the school.
Right.
Now, if I'm no longer a part of that company and they don't provide another counselor to the school, then that's why I'm asking, like, you know, if we're having.
I don't have the answer to that, but it sounds like if you're in a situation where there's not a plan in place, you need to ask what the plan is at the school. And if there's not a plan, strongly recommend you need one. You need one. It is unfortunate. It sounds like it's at some schools there are more resources available than at others, and what we need is more consistent and really more investment from the state, right?
Well, in most, not the charters, but most regular schools that don't have like a special program like his, there'll be the counselors that are there.
Trust counselor.
They have some training. And then the social worker that comes, it could be one day a week. There's a psychologist that's there, you know, that's a couple days a week.
Yeah.
So they can help out. But things like the trust counselor used to be in all the secondary schools, and they're dwindling away and stealing money.
Right, and after this, I can give you some connections.
Great. Well, thank you very much all for those comments. It is unfortunate because I didn't present this, but the rate of suicide and the rate of suicidal ideation has been going up in adolescents over the past 15 years now. We saw this very nice pattern through 80s and 90s where the rate was going down, and we thought, this is awesome. We're making headway. Around 2000, it started going the other direction, and it hasn't stopped. So it's troublesome that we see that happening, but at the same time, we see the resources and number of people available in schools decreasing. They're going in opposite directions. But anyway, thank you for those comments. Okay, I mentioned there are safety planning apps. These are absolutely free. You can get them. The address is probably way too small to see, but if you have the PowerPoint, you've got the address there. This is just one of the safety planning apps. I believe this is through SAMHSA. It's easy to download on your phone. If you're working with adolescents who have iPhones, this is great. As long as they've got a battery, they can have their safety plan right in front of them.
While we're on that topic here, I'm ignorant when it comes to technology, but we're living in a very modern age. There are apps for everything. I guess my question for you, in light of the recent live streaming suicides that we've seen in the last 90 days, for instance, in our own backyard here. I guess I want to pick your brain on what your advice as far as training is concerned for the frontliners, parents, clinicians, caseworkers, in addressing the same, there are great applications that we can have, with the phone and with social media, but then now it's probably gonna be a trend where we're gonna have suicide contagion. People are live streaming very tragic events and moments of their lives. So what kind of advice or suggestions do you have in addressing those specific issues as it relates to social media?
It's a great question. And so iPhone and things like that, those are simply tools. It can be used for good purposes, for not good purposes. But when it comes to something like safety planning, I think it's very helpful because if it's one thing adolescents have with them, it's their phone. So if they need to access the safety plan, they've got it there with this sort of app. Now, in terms of how do we respond to these live streaming, really tragic sorts of things, I wish I had a good answer for it. I think we respond the same way there would be any other sort of tragedy in terms of providing the counseling, the support.
But thinking in terms of prevention. I mean, we know they're out there. We know they're on Facebook, right?
Yeah.
We know that they're on social media, Snapchat or whatever else. So we have that information there. How can we utilize it, I guess, to help those teens that are either seeking help that way, and here we are, we know they might be seeking help that way, but we're not tapping into that source of information that could be very valuable in safety planning, in interventions, in treatment, et cetera, et cetera.
So you're talking big picture, like what might be the role of
Big and specific.
Of Facebook and I know that is a dialogue that's going on about companies like Facebook, if there's certain things that are typed into it or messages that appear, that they can jump in and intervene as an organization to provide messages of hope, or hey, here's a hotline number, sounds like you may be in distress. I
think there's a presentation, one of the keynote presentations talked about how, a teen can be online. And I don't remember if the app is called Coco, but then it can pop up, something pops up to provide, assistance or crisis assistance.
Yeah. Those conversations are happening, and there are some groups like Facebook that are open to that and are trying to figure out ways to make that happen. So if someone...
Predictive marketing.
Exactly.
We're predicting
exactly.
marketing
Yes.
suicidality.
Yes. Yes. Like recommending,
Right.
hey, sounds like you may be in some distress. Here's a hotline number to call. Some of that's happening. Hopefully it'll...
But in the meantime, and I'm sorry to monopolize this here, but we have, the teens, their social network is on Facebook, right, or whatever else. Maybe educating the teens about that, recognizing, because the last one, for instance, I believe, 1,000 people watched the live stream.
Yeah.
Nobody really intervened except two. And it was too late by the time, one of them actually called the police. So I think in terms of educating people and frontliners and even the youth themselves, maybe that's something to look into also as far as suicide prevention.
Something similar to like the See Something, Say Something campaign, or kind of equipping other teens with kind of the minimum, what they might need to, what they could say that would be helpful, or refer to someone who could be helpful. I think it's a reasonable next step, something that we'll have to deal with as technology continues and develops. Oops, wrong one. Okay, safety plan can also be a useful assessment strategy. As I said before, if an adolescent can't work with you to develop a safety plan, you're doing all the work, generating everything, well, that gives you some valuable information about his or her risk level. It means you can't really be certain that they're going to be safe, and maybe more restrictive action needs to be taken. Same is true if you're working with parents, and parents don't seem to appreciate the seriousness of it and are on board with means restriction. You may need to take more restrictive action to keep that adolescent safe. Okay, final point about safety planning. End the session on a positive note. Try to boost the adolescent's mood. Some examples of what people have done and recommended to do with this is at the end of, you've developed the safety plan, you've reviewed it, everyone knows what the deal is. Then spend some time talking about positive things. Develop a list of reasons for living, the good things in life, the things that keep me going. Or collaborate with the parents to develop a list of the adolescent's positive qualities or strengths. trying to end on a positive note, instill some good mood and some optimism as you're wrapping up your session with them. Okay, now on to documentation. This is an important point. Always document the risk designation, the rationale for the risk designation, and the courses of action that you took. I have a recommended template. Of course, you use whatever you want to use. This is just my recommendation for how to do it. You begin by, and I'll show some examples. You begin by listing the risk designation. Then you describe the nature and frequency of the suicidal thoughts or behaviors, including the presence and absence of detailed plans, preparations, and intent. You describe the steps you took to reduce the risk, including notifying parent, developing a safety plan, and then you list what the next step is going to be. So here's just one example for someone at mild risk. An example note. Lisa is deemed to be at mild risk. She endures feeling sad most days and having thoughts of wishing she were dead that occurred 1 to 2 times a week. She denied past history of suicide attempt and plans or preparations for harming herself. Pretty simple, pretty straightforward. Now that doesn't list the courses of action yet. All right, here's a sample for high risk. John is deemed to be at high acute risk. He endorsed a non-fatal suicide attempt 1 year ago by taking approximately 10 Paxil pills. He reported a weak desire to live and thoughts of dying 2 to 3 times a week when he feels stressed about school. He said he's not made plans or preparations to kill himself and that he does not have the courage to kill himself because he's afraid of experiencing physical pain and hurting his family. This is kind of lengthy. If you prefer shorter notes, that's fine. But the point is, list the designation and then give at least some explanation for how you arrived at that designation. It's not sufficient just to say mild risk, period. That's not going to do it. You need to give some reason for how you arrived at that mild risk or that high risk. Okay? Now, this is a full note. Again, this is a little lengthy, but just a recommendation. The first part lists the risk designation. Child is deemed to be at mild risk. During the questionnaire, shall endorse a statement, I think about killing myself but would not do it. The assessor probed to elicit more information. Child denied current thoughts of suicide, history of suicide attempt, but indicated he sometimes thinks about death when he is sad and gets in trouble with his family. Most recent episode occurred 1 month ago. Child denied plans, preparations, or intent. Here we get into the course of action. After obtaining child's permission, the assessor notified the parent about the child's thoughts, and then child, parent, and assessor discussed their concerns and plans for child safety. A safety plan was developed collaboratively with the child and parent, which the child will talk to mother if and when he has thoughts of death again. The mother will ask about and monitor child's thoughts of death. Child's thoughts will be assessed at the next scheduled appointment. Again, you're probably going to want to shorten that, but that just gives you the idea of the topics that can be covered in the full note. Questions about that?
In the school system, we really don't do that. Unfortunately, we just
What do you do?
we do a scan and we say that we did a risk assessment, but we don't document anything. At least I've never seen it done, and they never told me to do it.
So you do a
have
risk.
any recommendations? Do it.
Yeah. Well, but this takes time.
You don't keep it on because
So you tell me what happens in the school. You do a risk assessment. You come to a risk. Is that written down anywhere?
it goes into the system as that someone did it.
Someone did a risk.
So they put risk assessment, so and so did it.
Yeah.
But that's it. I've never
There's no
seen
place to type
documents.
in any sort
No.
of. Elaborate. You want to jump
Yeah,
in?
maybe you have an answer because you're a social worker. They do more risk assessment sometimes.
Right, well, what I do is, all right, I'm not employed with Miami-Dade County Public Schools. I'm sorry if I already said that, but I'm employed with Borinquen Medical Centers, which is a FHQC. Okay. So we have two systems to document our work. The one which is our internal system to keep our notes, and then we have Cheers, which is the Children's Trust system. Now, I've had in the schools, in the school where I'm placed at, I've had within the last 2 months, I've had 2 self-harm, suicidal ideation types. And what I do is I notate, I document the risk assessment, courses of action I've taken.
Right.
Oh, that on the system, so.
But that's
But
not the
different
school
than
system.
Miami-Dade
Right.
County.
Yeah, no.
Oh, that's what you're talking about?
Really, I've never, and I don't know, do you know anything? You've been in the
Is it
system
scam
for long?
documentation alone though?
Yeah, I mean, the scam is just a referral, right?
Yeah, the
Yeah,
scam
but
is just
the
a
scan,
referral.
we are told to not put anything on it other than the codes.
Right.
So the code is a risk
Confidentiality.
assessment, and a risk assessment could be for cutting, it could be for suicide, it could be for whatever, no explanation.
Right.
You just put the basic on it,
Right.
and it goes in the queue, and
Right.
it can be seen by anyone.
Right,
It works in the school
on the
system.
scam itself, on the referral itself, I don't.
Right.
Right. Okay, so there are confidentiality issues because it can be seen by everyone in the school system.
Right.
Is there, I'm just curious, is there another level that would be accessible by mental health personnel working in the school system so that they could see this child has been assessed, wow, high risk, and here's why high risk?
No, just a risk assessment, that's it.
And it doesn't even say the designation. Just,
You accept it, I'm sorry, if they're at risk, if you deem them to be at risk, then what's the next step?
Right, you would refer them to somebody, right?
Well,
Referral.
it depends. It depends how at risk they are. If at that moment they're at risk, but it's not for them to be Baker acted or anything like that, and you did a risk assessment and everything, they stay in the school and nothing happened, maybe you called the parent, tell them, you know, this and this happened.
but none of that is
But,
documented.
well, and that's, in the scam, there's like parent contact,
Yeah, okay.
you know, parent contact, and that's it.
There is, because the students were, have been referred to me. Okay, I'm the mental health practitioner in the school. So, for example, this one student, she was, her teacher, some marks.
Right.
And she referred the student to me. Because the school knows there's.
Right, but the teacher knows that, and you know that, but
Right.
there's no
And
other way to.
There's no
In the
chart or
future, you're not there,
documentation.
another
Right.
mental health provider comes, or a counselor, or psychologist,
Yeah.
and they know that she had a risk assessment. She doesn't know what happened. Now, in the school system, we don't document anything that I know of.
And
And how would that really impact in the future, something happens to him and I didn't document anything, and having 3-4 schools or 2 schools, and going from one school to another is very hard to.
Sounds like there is, yeah. Sounds like a systemic sort of issue that needs to be addressed in a way that's going to be more helpful to people in the system working to be able to know what's been done, what's the risk, what steps should I take. And not being a school system, I don't know what the solution to that is, but I do know enough to know it's going to be complicated and there's going to be a lot of bureaucracy.
In the past, what they've said, the less that you write, the better.
Because?
They're protected, in case there's a legal issue.
Yeah,
Unless you
because
write,
every-
we can, you know.
Not necessarily.
For them it is.
Right.
The less they write, the better it is. Because they will say, well, we spoke with this one, or we handled it this way, but there's no
Right.
recording, there's no documentation of it. They kind of-
Even when we test kids.
That can go both ways. Because sometimes if you don't write much, you're opening yourself up for problems. But I understand. But you've got to do what you're instructed to do. So I understand.
Might read that and use it.
Yes.
In a way that he should not.
Yes.
Years down the line and, label a child.
Yes, I hear you. I hear you. Not an easy solution to these things, but I know we're running short on time, so I got to wrap up here. Let me summarize the key points here. 10 to 20% of adolescents will experience suicidal-related behaviors each year. The key areas of emphasis for risk assessment are past history of attempts or self-injury and current plans and preparations for suicide attempt. Safety planning is a valuable, relatively easy to implement management strategy, and clear documentation of risk assessment and course of action is imperative. Of course, you've got to do it within the constraints and guidelines of the system where you work. So I get that. Here are some hotline numbers that you can give out, some in English, some in Spanish, some websites with more information if you want to look this up. There's the SAMHSA Suicide Safe app for iPhones if you want to share that with some adolescents or families that you're working with. And this is on what's been emailed to you. And my final point here, I want to end on a positive note, say that suicide can be prevented. It can. And if you don't believe my words, look at the data. These are all individuals who attempted suicide, fortunately did not die, and then went on to do some pretty remarkable things in life. Maybe you share this with some of the adolescents you work with to let them know they're not the only ones who's gone through a tough time. Others have as well. Others have even tried to end their lives. Fortunately, they didn't, and they went on to accomplish amazing things.
All right, thank you.